The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting the podcast. And thanks to everyone for listening in. Today's topic is going to get back into a Medicare Advantage plan controversy here. So in the past, we've talked about overpayments and things of that nature and risk adjustment. And I've made the case that CMS is probably going to really attack MA plans on these overpayments on the revenue front. Today, I want to talk a little bit about where I think CMS is going to go and already has started to go on an expense front. And it is making MA plans look a little bad. And I think it will become a lightning rod moving forward unless plans really take this seriously and begin reforming how they approach supplemental benefits. So that's just sort of a quick, admonition to MA plans. You need to worry about revenue overpayments, but you now also have to worry about getting your arms around supplemental benefits and whether enrollees are benefiting from the vast amount of dollars supposedly earmarked for their utilization each year. And we will get into that in more detail in a minute. This is yet another complicated subject, so we're going to try and break it down. And of course, we'll take a couple of breaks as well. So let's start out with a rate setting quick primer again, because you need to understand how supplemental benefits tie in on the expense side of MA plans. So as we've discussed on my blog and podcast often, the rate setting process in MA has helped MA plans grow considerably. And why do I say that? Well, plans submit annual bids on how much it will cost to deliver traditional Medicare benefits. Because the Medicare fee-for-service system is so fraud-ridden and inefficient, plans generally throughout the country can deliver those traditional Medicare benefits at a fraction of the price, depending on how bad the inefficiency and fraud is in a given region, will determine what fraction that is. It could be anywhere from 70% to, say, 85%, for example. When it bids on what discount it's going to be able to deliver those traditional Medicare benefits, plans are then paid out a portion of the difference between the county benchmark rate in their area and the bid amount for traditional benefits. I won't go into all the issues related to the county benchmark, but in general, nationally, it's supposed to be targeted right around 100% of fee-for-service. It's a little less in urban counties, and to incent people to have plans in more rural counties, the reimbursement is over fee-for-service, but it's supposed to be about 100% or so, the county benchmarks nationally. Again, this is called the rate rebate that we're just talking about, the portion of the difference between the county benchmark and the bid amount for traditional benefits is the rate rebate. The amount given back to plans can vary based on their star score and whether it hit 4-star and above. But the rebate is absolutely considerable to plans. Now, what do plans do with that so-called rate rebate or quality bonus, depending on how high you score? Well, these rebates must be given back to members in the form of additional benefits. In some cases, these additional benefits can be filling in gaps in the traditional program. One good example here is the inpatient benefit. We know it's got a lot of holes, it's capped, it's got very high cost sharing, and so many plans will add to the inpatient benefit. Or they reduce cost sharing from the traditional benefit for traditional services. But a great deal of the dollars of these so-called rebates are used on supplemental benefits, which are benefits not offered in the traditional program. These benefits have proliferated over the years as more people enrolled, as competition grew, and as CMS itself expanded the possibilities for such benefits. What I want to do here is give you a quick overview now that we've sort of described where these benefits come from through the rate rebate. I want to give you a little definition of what these supplemental benefits really are. So they have, again, been around for years and have fit into a few different types. So the first type that's been around for quite a long time are more narrow and traditional supplemental benefits that are primarily health-related. Again, these are the earliest and most prolific of the supplemental benefits. Indeed, the regulations historically may or may not have clearly spelled out the ability to even include some of these benefits over the years, but they were approved by CMS when the bids were approved. Plans proposed them, and again, CMS signed off on them, whether the regulation necessarily said them directly. The major ones in this more narrow traditional supplemental, primarily health-related benefits include the following. Vision, which could be exams or eyewear. The traditional fee-for-service benefit does not really have a strong vision benefit and only is targeted more toward diseases of the eye. So a vision benefit is a very big supplemental benefit, periodic eye exams, as well as eyewear. Again, eyewear is not generally covered in the fee-for-service world unless there are very specific disease states and reasons. Dental. Again, dental is not provided in the traditional benefit, and these supplemental benefits provide exams and other services, including dentures. Hearing. Again, hearing is not a traditional benefit, and supplemental benefits here would be exams and hearing aids. A fitness benefit, very, very popular right now to keep seniors and the disabled fit. Over-the-counter drugs are often done. These are your non-prescription drugs that are expensive and members need, and that benefit is offered as well as a supplemental. Remote access technologies, monitoring devices, and things like that. Post-acute meals are offered when you are in the hospital and you come out and cannot cook. And then also non-emergency transportation, largely to doctor's visits and things like that. So those were the original traditional supplemental benefits that were primarily health-related. Now, in recent years, CMS has also expanded and clarified the primarily health-related supplemental benefits. In 2019, CMS clarified to address existing ambiguities with supplemental benefits on what could be offered and expanded this category as well. It also allowed plans to waive the so-called uniformity mandate. Now, the uniformity mandate traditionally said that plans had to offer every benefit to every member enrolled. That's what uniformity was known. But in this 2019 ruling on supplemental benefits, uniformity could be waived here by allowing benefits not to be offered to everyone in the plan, but allow targeting of supplemental benefits to subsets of the enrollee population based on clinical conditions. So a good example here is you might offer non-emergency transportation to everyone in some form, but you might expand your transportation to additional areas, and that might be only covered for a subset of the population. Another good example is cost-sharing waivers was also allowed with this waiver of uniformity. So you could create a supplemental benefit for waiver of cost-sharing for certain things to members with certain disease states, as an example. So again, in this expansion of supplemental benefits in 2019, they clarified that existing supplemental benefits that had been approved for years were allowed. They expanded the categories, and I'll tell you a little more about that in a minute. And then they also waived uniformity so that supplemental benefits could be targeted to various subgroups on a clinical basis, certain comorbidities or disease states. So some of the benefits that were now clearly spelled out and added with this 2019 ruling from CMS included adult daycare services as an expansion, home-based palliative care, in-home support services, which to some degree were offered before, support for caregivers of enrollees, medically approved non-opioid pain management, standalone memory fitness benefit, home and bathroom safety devices and modifications, non-emergency medical transportation, which was originally offered but now could be offered in greater degree, and over-the-counter benefits, which again was a clarification. So that gives you a feel for what happened in 2019 to sort of expand health-related supplemental benefits. Now, in 2020, CMS expanded things even further, and they allowed the offering of not primarily health-related benefits to eligible chronically ill enrollees. The item or service must have a reasonable expectation of improving or maintaining the health or overall function of the chronically ill enrollee. A chronically ill enrollee was defined as one that, one, has at least one medically complex condition that is life-threatening or significantly limits health or function, two, has a high risk of hospitalization or other negative health outcomes, or three, requires intensive care coordination. By their nature, these benefits are targeted to a subset of the enrollee population, which would be the chronically ill enrollee. Examples of these, what they call SSBCI benefits, special supplemental benefits for the chronically ill, include food deliveries, expanded meal deliveries, expanded transportation, general supports for living, social need benefits, self-direction supports, groceries, additional home modifications, personal care items, and even housekeeping. Now, with regard to these chronically ill benefits, CMS, effective 1/1/25, is requiring MA plans to demonstrate by the time they submit bids that such items and services they're proposing in the benefits meet the legal threshold of having a reasonable expectation of improving the health or overall function of the chronically ill enrollees, and that it is supported by evidence-based research. So this is one small part of the controversy and reforms that CMS is trying to tackle here. So now that we've talked about the rate rebate and how that supports supplemental benefits and talked about what kind of supplemental benefits are offered in MA, we'll take our first break and then we'll get a little bit into the supplemental benefits controversy.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back. We hope you're enjoying this podcast regarding the supplemental benefits in Medicare Advantage. And now we're going to turn to the controversy here. But before I do that, I just want to give you a little overview of the penetration or proliferation of supplemental benefits and the increase in rebates. So we know that MA rebates are growing considerably because of enrollment and for other reasons. The 2023 Medicare Trustees Report estimated that there are $67 billion each year spent on rebates, at least in 2024, and that will rise as well. In 2022, over 99% of MA plans offered at least one supplemental benefit, and the median number of supplemental benefits was 23. Now, that's pretty amazing. That is a lot for a plan and a lot for members to keep track of. And the fear here, and this is part of the controversy, is that utilization of many of these benefits is very low. Plans will place utilization statistics into their bids for use of the rebate, and nobody quite knows whether the utilization is there or not, and it likely is very low. And people are beginning to ask the questions about how does utilization tie to what's in the bids for the utilization of the benefit, at least what is predicted for utilization. So this is where we start to get into the controversy. So I'm going to start now first with a January 2023 Government Accountability Office report that was very detailed and frankly very good on supplemental benefit offerings. They did a real deep dive. And again, over the years, numerous groups have documented in analyses that no one is quite sure how much of the rebates are actually spent or what the utilization is. But this January 2023 GAO report really is a worthy read and really went in depth, despite not having a lot of answers about supplemental benefits. So the January 23 report pointed out several different things. Number one, it went through the various types of supplemental benefits, as I just did here, but in greater detail. It notes that spending on the benefits by plans vary greatly, and that's very interesting as well. It states that little is known on spending, again, due to the lack of encounter data submission, and we'll get into that controversy shortly. And it finds that there is no way right now to accurately tie back bid information, as I noted, on such benefits to actual utilization, primarily because of the lack of encounter data submission. So it was a very, very hard-hitting report, generated headlines, was circulated on Capitol Hill, and it has become part of opponents' talking points. GAO recommended that CMS do a few things. Number one, it wanted them to clarify that supplemental benefit utilization must be submitted as encounter data to CMS, just like all of the other traditional services out there. And it also said that it should have clear directions on how to do so, given how different many of these supplemental benefits are from traditional health benefits. And we'll talk a little more about that in the future as well. Similarly, in its March 2024 report to the Congress, Medicare Payment Policy, MedPAC, the Congressional Medicare Policy Advisor, took MA plans to task on supplemental benefits as well. Like the GAO, MedPAC cited major dollars allocated to the benefits and little way to analyze the value actually provided. MedPAC cited a study by the actuarial firm Milliman. Milliman analyzed 2018 MA claims for 1.9 million beneficiaries who were 65 or older and enrolled in plans that provided dental coverage, one of the big traditional health-related supplemental benefits. Milliman found only 11% of enrollees had MA-covered claims for preventative dental. MedPAC also cited a trade association study that found only 33% of eligible beneficiaries used OTC benefits during the year. MedPAC also noted data released by Elevance Health, a very big MA provider, that showed low utilization of supplemental benefits in its plans. So these three things, Elevance Health, a trade association regarding OTC benefits, and Milliman's analysis of dental claims all pointed to very low utilization, and it clearly did not match what plans are filing in their bids to spend some of that rebate dollars. So let's talk a little bit about how opponents of MA are sort of tying the overpayment issue to this supplemental issue here. And I'm going to cite just one quick example. The American Prospect, a progressive publication, covered that MedPAC report I just talked about. I disagree with a great deal of what is cited by the American Prospect in their article, which actually goes beyond supplemental benefits and covers a whole range of things. But I refer to it because this is what many on Capitol Hill are reading or hearing about. Not only progressives, but conservatives who want greater accountability and hate corporate welfare. The American Prospect argues against MA on the overpayment issue in this article, citing numerous areas, and then links the supplemental benefits controversy to it. It says supplemental benefits are massively subsidized by the government through the rate rebate, and that the benefits are simply used to drive more and more enrollment at no real value to the members. It recounts that all this happens to benefit MA plans and big companies, and no dollars are allocated to the other half of Medicare beneficiaries for any benefit enhancements. So you can see what they're doing here. They're talking overpayments and over reimbursement to corporations. They're talking supplemental benefits that is a form of corporate welfare in a slightly different way, that is driving more and more enrollment to benefit these big MA companies. And it's being lowly utilized and has no real value to members. And all the other half of Medicare enrollees in fee-for-service are suffering because no dollars are being allocated to them. Again, this is what is on Capitol Hill, and it's very, very worrisome for MA plans. With that, we're going to take our second break and tell you what CMS's response has been to the GAO report as well as to the MedPAC report.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we're talking about supplemental benefits, and we've just gone through some of the criticism and some studies about low utilization. And what we're now going to do is talk about some responses from CMS to counteract these criticisms of their regulation of supplemental benefits. So in response to the analyses, MedPAC and the GAO, and due to its own honest ongoing concerns, CMS took 2 steps in 2024 to get their arms around supplemental benefits and ensure value is being delivered. So the first thing they did is they issued a memo on requirements to submit supplemental benefits utilization as encounter data. As we talked about, this was one of the recommendations from one of the 2 reports. While many argued the regulation was clear that all encounters should be submitted as part of the encounter data gathering process in MA, whether they were supplemental benefits or regular benefits, the fact is that supplemental benefit data largely was not being submitted by MA plans. 3 factors really impacted the reporting. MA plans claimed the regulations were not clear on submission of supplemental data as encounter data. Sufficient direction as to how to submit supplemental benefit encounters was not spelled out by CMS. And many supplemental benefits are not health related or cannot be reported cleanly as medical services can. For example, while some supplemental benefits like dental can be easily submitted in HIPAA type formats, some benefits do not match traditional encounter structures at all. They do not have procedure codes and more. So all three of these points were reasonably fair from the MA plans. I'm not sure that it clearly said that supplemental benefits should be submitted. I think it probably was there, but it wasn't particularly clear. I agree that there wasn't sufficient direction, and certainly the submission and the procedure code and other HIPAA formatting issues were clear. I would also say, even though I'm an advocate of MA, there's a fourth factor about why these things weren't submitted, probably because utilization was very low, and plans clearly did not want to disclose that either. Well, all those points aside, let's talk about the memo that was issued by CMS. So CMS attempted to tackle all of these rebuttals to submission of supplemental data as encounter data in a little talked about February 21, 2024 memo, as well as some supplemental memos issued providing technical details for submissions through the encounter data system. This February 21 memo made submissions of supplemental data retroactive to 1/1/2024. So, to deal with the issues raised above and to also ensure that when this supplemental data to the encounter system was submitted, it would not be rejected because certain fields were not captured or had accurate values. The memo and the supplemental memos make it very, very clear how MA plans should submit supplemental data as encounters. The plans really, really have to thoroughly review the memo as well as the additional submission guidance. CMS made it very clear that that memo, and I think they're probably right, should cover all benefit types to allow for full submissions of these supplemental data. But it is very complex, and it still leaves a lot to work through. And so I do expect numerous updates and bumps in the road over the next several years. But for the first time, plans do have what I think is a reasonably accurate roadmap from CMS on how these supplemental benefit types should be submitted. Plans will need to master the nuances of submitting for each supplemental benefit type. One of the biggest challenges for plans may be the requirement that plans report each individual utilization instance when a supplemental benefit is used. That's generally the standard outlined by CMS, but the guidelines actually do make some exceptions. For example, for the use of debit cards and fitness centers and things like that. Utilization for a member can be submitted in sort of groupings for certain benefits. But this clearly will be a major point of contention for the plans well into the future to figure out how they really do break out some of these benefits into individual utilization instance, even with some of the allowances. Default codes for supplemental benefits were published to try and address the difference between healthcare services and non-traditional and non-health related services. Hopefully, programming that CMS does related to default codes will take into account that certain submissions will not have other traditional fields filled out as well. With regard to, for example, to diagnosis and procedure. So a whole lot has to be figured out here. There's no question. But again, plans do have the roadmap now on how to submit these. They need to start that process. They need to talk to CMS about any problems they are having and document any system or other issues. Let's next talk about the second big thing CMS did in 2024. Well, it's called the 2025 MA and Part D rule. The rule was finalized in April. And again, CMS is very concerned about the lack of use of supplemental benefits and the high costs put in bids by plans. The question that CMS is raising is, are supplemental benefits shadow benefits built into rates but not utilized sufficiently, if at all? Plans market these benefits when enticing enrollees to join, but do they essentially pocket the dollars when utilization is low? Perhaps even though there is a minimum medical loss ratio requirement for MA. Again, CMS supports the provision of supplemental benefits, especially in the area of social determinants and the chronically ill benefits. They think done correctly, it will have tremendous value, but it does want to ensure better oversight. To ensure the large federal investment of taxpayer dollars in these benefits is actually making its way to beneficiaries and are not primarily used as a marketing ploy, the 2025 rule published by CMS requires MA plans to do the following as of 1/1/25. First, they must engage in minimum outreach efforts so that enrollees are aware of the supplemental benefits available to them. Second, they must issue a mid-year enrollee notification of unused supplemental benefits annually, personalized to each enrollee, which would include a list of any supplemental benefits not accessed during the first 6 months of the year. In addition, the notification must include the scope of the benefit, any cost sharing required, and network or restrictions to any of those benefits, how to access the benefit, and a customer service line if additional help is needed. Last, they need to prevent misleading marketing related to supplemental benefits. The rule makes it a violation to feature benefits that are subset to given populations as available to everyone in the plan. This was one major concern and one major complaint from CMS as well. So there you have it. Two major things that CMS has done to get their arms and oversight around supplemental benefits. First was the requirement to submit supplemental benefit utilization to the encounter data system, along with all the other encounters. And number two, they passed this MA and Part D 25 rule that lays out minimum outreach efforts, a requirement for a mid-year notification of unused benefits, and a prohibition on misleading marketing of supplemental benefits. So with that, we'll take our last break and we'll come back to talk a little bit about what I think plans really need to do here.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this podcast on supplemental benefits and Medicare Advantage and the controversy surrounding them. As I noted, after significant scrutiny, CMS did respond to the criticism in reports and on Capitol Hill and from opponents of MA on supplemental benefits accountability by enacting a number of reforms we just went through. CMS will have to deliver on them and ensure it has adequate oversight on the implementation. It will be up to MA plans to not only get supplemental benefit encounters in the encounter data system, but meet the new 2025 rule as well. More to the point, I really feel like MA plans really have to commit to driving supplemental benefit education of members and utilization of those benefits. I don't think anybody doubts, and I'm an advocate of MA, that the supplemental benefits is underutilized, and frankly, that some plans use them more for marketing to grow than to offer real value to members. I think supplemental benefits are one of the great value differentiators between MA and the traditional program. The fact that so much growth has happened shows that. But what would happen to enrollment growth if supplemental benefits really began to be utilized? That value differentiation would shoot through the roof. Yes, plans would have to spend slightly more money, I guess, but I think the value differentiator would be so great that it would really put a stake in the heart of fee-for-service once and for all and actually accelerate the move of people to MA. On the flip side, what might happen? Well, if MA plans have a poor record on submission of encounters and they do not drive utilization of the supplemental benefits, all this could backfire on MA plans. It could add to complaints that MA is not all it is cracked up to be from both a cost and quality standpoint. With that, we'll end this edition of the Healthcare Labyrinth Podcast, and we'll see you on the next podcast. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.